Budan, an educational initiative from ISA Pudukkottai City.
Sir, unmute, sir.
Sir, your voice has gone.
Yeah. Welcome everyone.
Yeah.
Today we are starting the 46th webinar. Pudukkottai Budan, ISA Pudukkottai City Branch Educational Institute. Today we have some interesting topics. Accidents during drug administration in anesthesia. Then we have record keeping in anesthesia. And on a new drug, we are going to discuss Sugamadex. At the outset, I invite our treasurer, secretary, Dr. Periyasamy, to deliver the welcome address and introduce the speakers. Over to Dr. Periyasamy.
Thank you, sir. Respected Academic Chairman Dr. A.L. Sundaram sir, President Dr. Suresh Kumar sir, Treasurer Dr. David, and members of ISA Pudukkottai City Branch, and delegates, those who are attending this program from the beginning. Today, I welcome you all on behalf of ISA Pudukkottai. First of all, I would like to thank the participants and the delegates, those who are attending this program from the beginning. The days last March 23rd, 2022 onwards. Today, we entered 46th online ISA webinar program, Pudukkottai Budan. Once again, thank our academic chairman and president, treasurer, and members of ISA Pudukkottai for their continuous support and make this program become very alive, live, and more important program in all over the country, making it one of the most important program all over the country. And this is the 46th program for this. Already we conducted 45 programs. These are the list of different topics and different headings, and so many speakers, eminent speakers from all over the India participated in this event and make this program very eminent and most important one for PGs and practicing anesthesiologists all over the country. Today we are having three important topics. One is accident during drug administration, and another one is anesthesia record keeping, and third one is the new drug Sugamadex. For that, I invite Dr. Ashok Vasanta Rao, HOD, Department of Clinical Skill Lab, Party Medical College, Sangli, Maharashtra, and GC member ISA National as a chairperson. On behalf of ISA Pudukkottai, I welcome you, sir. Next, I would like to invite our past National President, Dr. Venkatagiri, sir, to talk about accident during drug administration. On behalf of ISA Pudukkottai, though you are a regular invitee in our online ISA webinar program, once again I welcome you, sir, for this important event. Welcome you, sir. And next speaker, Dr. Briyadarshini, senior resident, Katpaka Vinaga Institute of Medical Science, Tamil Nadu. Madam is going to talk about anesthesia record keeping. I welcome you, madam. And third topic is Sugamadex. Is going to talk by Dr. Dilip Kumar, resident, Mysore Medical College and Research Institute, Mysore. On behalf of ISA Pudukkottai, I welcome you all for this 46th ISA online webinar program once again. And if you are having any doubts and queries, you can send your mail to this isapudukkottai@yahoo.com email ID. This is our official email ID. You can contact for any clarification. With this, we are going to talk something new about anesthesia mistakes. So, small note about that, accident-free anesthesia. So alertness needed during anesthesia for all and activeness needed during anesthesia for all. Use your eyes and ears before you act. Look, listen before you inject. Look, listen before you inject. Afraid of failure is afraid of your loss. Afraid of failure is afraid of loss. Always learning, making you as your boss. Being alert is the best defense. Being alert is the best defense. Workplace safety is a work of all. Workplace safety is the work of all. So, avoid accident, accompanying the patient always. If you keep this, anesthesia is a pleasant journey. With this, I thank you all and over to President Dr. Suresh Kumar sir. Thank you, sir.
Thank you very much, Dr. Periyasamy. Welcome today, respected Secretary, Treasurer of our branch, dear Academic Chairman, Dr. A.L.M. sir, respected Chairperson of this webinar, Dr. Ashok Vasantrao Deshpande sir from Shangli, Maharashtra. Today's speakers, Dr. Venkatagiri sir, Dr. Priyadarshini madam, and Dr. Dilip. Members of ISA Pudukkottai branch, postgraduates, practicing anesthesiologists, and participants of today's webinar. I welcome you once again as President of ISA Pudukkottai branch. I want to just recollect and refresh, and those who are attending first time in this webinar about Pudukkottai Budan. Pudukkottai Budan, we started 11 months back as an educational initiative, especially targeting budding anesthesiologists and practicing anesthesiologists to update the knowledge and regarding the latest advances of anesthesiology, so that it will be useful for their practice. Especially we are giving a solid platform for the resident anesthesiologists, so they can use their skills in talking in this webinar, presenting in this webinar, which will be very useful for their successful career. And the Pudukkottai Budan has grown to such a great level. We have here today our President Sark is giving a talk on accidents during anesthesia. So the importance of Pudukkottai Budan has come very true. All credits go to our academic chairman, Dr. A.L.M. sir. At this juncture, I once again thank him. Thank you, Dr. A.L.M. sir, for this wonderful initiative. Regarding the platform, we are having so many specialists and celebrities of anesthesia joining here every week, which we are witnessing every week. At this juncture, I once again welcome you all for this webinar. I request you to make use of this program every Wednesday to uplift your and update your career. I hand over the proceedings to Dr. A.L.M. sir. Over to Dr. A.L.M.
Thank you, respected President ISA Pudukkottai, dear Secretary, Treasurer ISA Pudukkottai, and special thanks to Dr. Chakra Rao, Chairman, Indian Resuscitative Council, who is attending this. And we are happy to have him as a listener. He was a speaker. Now, as we are having past national president ISA, Dr. Venkatagiri is also a speaker. So our secretary, Dr. Bajua, delivered a lecture here. Then our previous GC member, Dr. Jana, participated. Now the present GC member, Dr. Deshpande, is the chairperson. So definitely, the ISA Pudukkottai is having a national color. And today, to prove that it is a national webinar, we are having one speaker from Karnataka, Dr. Dilip Kumar, one from Tamil Nadu, Dr. Priyadarshini, one from Kerala, Dr. Venkatagiri. chairperson from Maharashtra, and the listener Dr. Chakarrao is from Andhra Pradesh. So many people are participating, and even many from Andhra, they inquired me, sir, we have not received any communication. What is today in Wednesday? So that sort of appreciation we gained, and thanks to Team ISA Pudukkottai for this wonderful opportunity. And today we have the youngest speaker, Dr. Dilip Kumar from Mysore Medical College. He is a final year resident. And thanks to Dr. Manjunath HOD, who has mentioned his name to talk about Sugama Dex. And immediately many questions were coming up regarding Sugama Dex. And I am sure that postgraduate youngest man has our plan always to have a youngster in the webinar. So today he is standing, rather sitting as a youngest speaker. So this man is from Mysore Medical College and Research Institute. So people, youngster will be loving so many things, but this man loves only food and music, and he is touring every area just to taste food. And his hobby, just like any other youngster, watching movies, but he is interested in seeing only Kannada movies, I think, as he is from Mysore. So we are happy to have him as the youngest faculty, and he is co-speaker with the great Dr. Priyadarshini Venkatagiri and chaired by our GC member. Next speaker is Dr. Priyadarshini, who volunteered herself to talk about anesthesia record keeping, which is very, very difficult area. And she is from Karpavanaga Medical College. And we thank Dr. Shanta Parthiban also, who has mentioned her name. And Madam is from Chettinad Hospital as UG and PG from Jawaharlal Nehru Medical College, Belgaum. Again, she was from Chettinad Hospital, Belgaum, and now in Kanchipuram, Karpavanaga. She is interested in presenting papers, even as a senior resident. She has published a paper comparing volume controlled ventilation and pressure controlled ventilation in post-COVID situation, mainly mucormycosis. Then she has presented a paper on achondroplasia dwarf. Most commonly, most rarely, she has presented a paper on obstructive sleep apnea, babies posted for adenotonsillectomy. So we are happy to have her as a speaker. Then Dr. Venkatagiri need not be introduced. Dr. Venkatagiri is just Dr. Venkatagiri, that's all. So he is a most popular man from Kasaragod. So he is good at speaking Malayalam, Kannadam, Tulu, English, Hindi. So he knows 5 languages, and he knows only 5 words in Tamil. Vanakkam sir, Magilchi, some 5 words, even after knowing 5 languages. And Venkatagiri is our ISA national past president, and he is a SARC president. He is a good organizer. He has organized many conferences, and his hospitality is phenomenal. We have visited several times this Kasaragod area because of him, and he was the former secretary of ISA National. So he has become a president also. Now he will be the scientific chairman, immediate past president. So Dr. Venkatagiri, we are happy to have Dr. Venkatagiri as our faculty. And just because Venkatagiri is participating, we wanted to be very careful in selecting the chairperson. So we have selected the fittest chairperson, Dr. Ashok Vasantrao Deshpande. We call him as Deshpande only. So he is Dr. Deshpande. He is living in Sangli Miraj, which is the remote corner in Maharashtra. But in Sangli Miraj, he is a freelancing anesthesiologist for more than 40 years. And he is a more popular person here. He organized ISA-sponsored CME in Sangli Miraj. Phenomenal. You cannot imagine the crowd which he attracted because of his academic career and the careful selection of topics. And I am very happy. I was also a participant in that Sangli Miraj. And he is a HOD skill lab. Skill lab is mandatory now, even as per NMC. He is trained in Mayo Clinic, USA. So he was the past ISA Secretary Maharashtra, ISA President Maharashtra. Now he is a present GC member, ISA National, and he is an outspoken man. He will not hide anything. He will not play cards close to his chest. He will always play with the open cards. And more than all these things, Dr. Deshpande attended my son's marriage. So at Pudukkottai, Pallatur village, he has traveled to Rangiam, my native place. So because of this ISA, I have visited the corner of Maharashtra and he has visited even interior of Pudukkottai. He was placed in Tanjavur. He was transported to Rangiam. He attended Pallatur. Dr. Chakrara was also there. So this sort of a thing, that association helped us to have a close contact with these people. So even though Dr. Deshpande sir is from Bharati Medical College, from Mayo Clinic, whatever you say, HOD Skill Lab, ISA Secretary President, everything of Maharashtra, he is Deshpande for me. So he is such a close friend of mine, and he was very happy. I am very happy that he has agreed to be a chairperson. So these two people, Venkatagiri and Deshpande, they are known to me like anything more than 20 years. I travel to their home. I know their family. So I want every one of you attending this webinar, please take part in ISA activities. That gives a phenomenal color. Knowing each other is a very good thing and it increases our confidence levels. So people like Dr. Dilip Kumar, they should come up to the level of Ashok Deshpande. So I request all of you to utilize this platform. So we are nearing 1 year. So at the end of 52nd week, we will be completing our 1 year. Then God only knows what is our destiny. ISA Pudukkottai has to decide. Now I hand over the session to Dr. Ashok Vasantarao Deshpande. For us, he is Deshpande, sir. Please, sir.
Come forward. Unmute.
Sir, Dr. Chakrarao, sir, you want to say something? No.
No,
Sir.
no, I'm very happy about this introduction.
Thank you, sir. Dr. Deshpande, sir, please take over.
Good evening, everybody. Good evening, the office bearers of the Pudukkottai ISA branch. And good evening, all the speakers who are there, who are delivering the lecture. Good evening, Chakrarao, sir, who is a very senior person and is attending over here. And I am really thankful to all the office bearers who has invited me as a chairperson over here. And I am lucky to have a chairperson of the session who is going to delivered by Dr. Venkatagiri, Dr. Priyadarshini, and Dr. Dilip Kumar. So I request now the first speaker, Dr. Dilip Kumar, to please take over and deliver his lecture. Dr. Dilip Kumar, please.
Good evening, sir. Thank you for your introduction, sir. First of all, I would like to start by thanking our beloved HOD, sir, that is Dr. Manjunath, sir, and also all the office bearers of ISA Pudukkottai branch for giving me an opportunity to talk in such a wonderful platform, sir. So, today I will be talking about a novel revolutionary drug, that is Sugamadex.
Make it full screen.
Dr. Slideshow. Thank you.
Sugamadex, it is a modified gamma cyclodextrin and it is the first selective relaxant binding agent which is based on an encapsulating principle for inactivation of a neuromuscular blocking drugs, especially the amino steroid group of neuromuscular blocking drugs such as vicuronium, proquinone. It was discovered by a pharmaceutical company named Organon in Scotland. It was approved for use in USA in 2015, and it was approved for use in European Union early than the USA, that is in the year 2008. Coming to the structure and mechanism of Sugammadex, it is an unmodified cyclodextrin which consists of either 6, 7, or 8 cyclic dextrose units which are joined through glycosyl bonds, and they are called as alpha, beta, and gamma cyclodextrins respectively. That is based on the number of dextrose units. So the structure has a lipophilic cavity in the center and the hydrophilic exterior because of the presence of polar hydroxyl groups. The three-dimensional structure, it resembles a hollow truncated cone or a donut shape. The cavity, it is modified for better accommodation of 4 hydrophobic steroidal rings of rocuronium inside the cyclodextrin cavity. This modification is possible by addition of extra side chains. By addition of extra side chains, the cavity is increased so that the steroidal rings of rocuronium is accommodated inside. The Sugammadex, it forms a rigid complex in 1:1 ratio with the steroidal neuromuscular blocking drugs. The affinity of Sugammadex towards rocuronium is 2.5 times lesser, but still high enough to form tight complex. Whereas in compared to rocuronium, when it is much, the affinity is much lesser. Whereas in pancuronium, it doesn't have a much clinically significant effect. And the rapid binding of rocuronium and Sugammadex, it results in removal of free rocuronium molecules which are present in the plasma. This concentration gradient, it favors the movement of remaining rocuronium molecules from the effective site. That is the neuromuscular junction. From neuromuscular junction, it enters the plasma, where the drug is encapsulated by the free Sugammadex molecules. The neuromuscular blockade is quickly reversed as rocuronium is removed from the binding sites at the neuromuscular junction. It has no direct or indirect action on the cholinergic transmission, unlike neostigmine. That is the reason we don't require to add an anticholinergic like glycopyrrolate or neostigmine or atropine, just like how we use along with neostigmine. So coming to the pharmacokinetics, the pharmacokinetic profile of Sugammadex, it is linear in the dose range of 0.1 mg per kg to 8 mg per kg. In the healthy adult, it has an elimination half-life of around 100 minutes and clearance of around 120 ml per minute. It is not metabolized and is excreted exclusively unchanged in kidneys. Interestingly, the administration of Sugammadex, it also alters the pharmacokinetics of rocuronium. With rocuronium, Sugammadex complex behaving in a very similar manner to Sugammadex, with the elimination of rocuronium being shifted up the biliary system to predominantly the renal excretion. Coming to the dosing, in India, Sugammadex is available in the formulation of 5 ml, that is 500 mg vial or 200 mg vial. It is produced or launched by BDR Pharmaceuticals along with Varanium Hospital Care. The dosages are for reversal of moderate neuromuscular blockade, that is 2 twitches in response to train of force stimulation. 2 mg per kg of Sugammadex is required. For a deep blockade where 1 to 2 post-tetanic counts are there, 4 mg per kg of Sugammadex is required, and 16 mg per kg for immediate reversal following an intubating dose of rocuronium, that is around 1.2 mg per kg. The recovery from a 2 or 4 mg per kg dose of Sugammadex is significantly faster than antagonism with neostigmine, allowing the achievement of train of 4 ratio of more than 0.9 in an average of 3 minutes. Furthermore, Sugammadex can also reverse deep block faster than what neostigmine can do. So while rocuronium and becuronium should be dosed according to the ideal body weight, whereas Sugammadex, it should be dosed according to the actual body weight. This is the table which is showing the dosage recommendation to reverse the rocuronium blockade. As I said earlier, it is around 16 mg per kg after an intubating dose of 1.2 mg per kg of rocuronium, 4 mg per kg dose for a deep block, 2 mg per kg for a moderate block, 1 mg per kg if there is 4 twitches after train of force stimulation, and 0.22 mg per kg when the TOF ratio is around 0.5. So what are the clinical implications of Sugammadex? Let's compare the Sugammadex along with neostigmine. Neostigmine, it is has well recognized undesirable side effects, and also it can result in variable reversal of neuromuscular blockade, as we all know. It also has the disadvantage of not being able to reverse profound depth of blockade. And if given during profound or moderate level of neuromuscular blockade, neostigmine can potentially exacerbate the neuromuscular block by direct action on the open nicotinic receptors. Early studies established that Sugammadex compared with neostigmine was superior in producing complete reversal of the neuromuscular blockade from both routine and moderate levels of block, occurring up to 17 times faster with Sugammadex. In clinical practice and during an unexpected difficult airway, that is a cannot intubate, a cannot ventilate scenes, a rocuronium neuromuscular blockade may be reversed by Sugammadex immediately in order to restore spontaneous ventilation. There are some case reports of successful use of Sugammadex in cannot intubate, cannot ventilate situations, warranting its inclusion on difficult airway trolley. Another postulated benefit of Sugammadex is facilitation of moderate to profound neuromuscular blockade till the end of surgery, so that the surgical operating conditions are improved. So Sugammadex and versus succinylcholine. Succinylcholine, that is what you call as succinylcholine, it has been the muscle relaxant of choice in rapid sequence induction due to its rapid onset and rapid offset of action. However, it is also associated with numerous potentially life-threatening adverse effects. Rocuronium, the dose of 1.2 mg per kg, can emulate the intubating conditions of succinylcholine for RSI, but with a consequence of prolonged duration of action, since rocuronium is an intermediate acting neuromuscular block. Administration of Sugammadex, even after high dose of rocuronium, that is at a dose of 1.2 mg per kg, can result in a quicker return of neuromuscular transmission when compared to spontaneous resolution of succinylcholine-induced blockade. Sugammadex at a dose of 16 mg per kg will reverse profound neuromuscular blockade within 1.3 to 1.9 minutes post-administration. So compared with succinylcholine, the use of rocuronium and Sugammadex to facilitate ECT has been associated with shorter recovery times and reduced post-operative complications such as myalgia or headache. So Sugammadex, it has been also postulated that it plays a role in treatment of rocuronium-induced anaphylaxis. Coming to Sugammadex used in specific population, in elderly, the recommended dose of Sugammadex is same as younger adult patients. However, the onset of action may be slower. In case of pediatrics, the routine reversal of train of 4 response count of 2 with Sugammadex 2 mg per kg in children aged between 2 to 17 is recommended. However, despite safe use in a small number of case reports, Sugammadex use is not endorsed in neonates or infants. Well, coming to pregnancy, there are not much documented cases of Sugammadex being used during pregnancy and is not recommended despite minimal placental transfer. In case of obesity, there is an ongoing debate surrounding the dose of Sugammadex in obese patients, as currently dosing is based on actual body weight. However, dose based on ideal body weight plus 40% of that dose appears to be a safer option. Dosing based on ideal body weight alone has been associated with slower recovery times and also may lead to increased risk of inadequate reversal. In patients with renal disease, Sugammadex use in patients who are having a creatinine clearance of less than 30 ml per minute is actually not recommended. Coming to the drug interactions of Sugammadex, mainly two types of drug interactions do occur. That is, one is capturing type of interactions and displacement interactions. Capturing interactions are nothing but the Sugammadex molecules, they try to capture other drugs, especially the hormonal contraceptives, the present in the plasma, instead of encapsulating the rocuronium molecules. So while capturing the other drugs, it reduces the efficacy of those drugs, especially the OCPs. So females who are on OCPs, they should be considering an alternative source of contraceptive methods when she is administered with Sugammadex past 7 days. And regarding displacement interaction, the Sugammadex rocuronium complex, if there are certain drugs such as diclofenac, fusidic acid, all these drugs, they have tendency to replace this rocuronium in this Sugammadex rocuronium complex, and it may have a theoretical risk of recuralization. So coming to the adverse effect, Hypersensitivity, even though it is rare, it is the most concerning adverse effect of Sugammadex. With the literature review of highlighting this can be severe and rapid in nature. That is, it can occur within 5 minutes. The incidence of hypersensitivity reaction is estimated at around less than 1% after a single dose. The likelihood increases as the dose increases and the frequency of Sugammadex dosing increases. The diagnosis can be confirmed by intradermal skin prick testing. Common side effects include dyspepsia, headache, fatigue, nausea, vomiting, dizziness, urticaria, and abdominal pain. Even bradycardia is also observed at higher doses. The FDA has raised concerns regarding the QTC prolongation. However, subsequent studies using doses of Sugammadex up to 32 mg per kg have demonstrated that there is no difference in QTC compared with placebo. A further issue which was highlighted by FDA was the effect of Sugammadex on coagulation due to studies suggesting that there is an increase in activated partial thromboplastin time, possibly due to inhibition of factor Xa. Animal studies have suggested that Sugammadex may be neurotoxic. Concluding my talk, Sugammadex, it is an effective and safe agent for reversing aminosteroid neuromuscular blockade, in particular all types of rocuronum-induced blockades. Sugammadex use has followed rocuronum to become a comparable alternative for succinyl choline for RSI. Despite all these virtues, there are still some concerns regarding hypersensitivity and cost effectiveness. Further research is needed to improve how Sugammadex use could be tailored for specific situation, for specific population, and become more financially viable. Some other references. Thank you. Thank you, sir.
Thank you. Thank you, Dr. Dilip Kumar.
Thanks, sir.
You narrated very nicely about the Sugammadex. Thank you very much. Now we have got a second speaker, Dr. Priyadarshan. And she is going to talk on anesthesia record keeping. Dr. Priyadarshan, please.
Yes, sir. Let me play.
Yeah.
Good evening to all the dignitaries present. Today will be a short webinar on record keeping in anesthesia. So what's a medical record? It is a document relating to patient care on which there is sufficient data recorded in a sequence of events to justify the diagnosis and warrant the treatment. It serves as a clinical, scientific, administrative, and a legal document. So this picture shows the very first anesthetic record, which was documented as early as 1895. This was almost nearly 50 years after the demonstration of ether anesthesia by W.T.G. Morton. So it was done by two eminent physicians, E.A. Codman and Harvey Cushing, who first recorded only the pulse rate and the respiration as the important physiological vital signs during the administration of anesthesia. So this anesthesia record further evolved to include various other physiological variables like systolic blood pressure, EtCO2, pulse oximetry, and other important physiological variables. And these are also examples of old anesthesia records, and it has evolved to a greater extent in the recent days. So what's an importance of an anesthesia record? Anesthesia is one specialty where there is abundant physiological and pharmacological data which is to be collected every minute to minute. This is because of the change in the patient's clinical condition within seconds, which requires very minute attention to every detail. And there is no arbitrary fixed time as to the sampling of physiological data, and that is also dependent on the rate of change of the patient's clinical condition. So, anesthesia record serves as a pre-anesthetic summary of patient information. It carries demographic, clinical, physiological, physical, and laboratory information pertaining to the patient. And it helps in detecting the intraoperative change in the trends of physiological variables like blood pressure and heart rate, and helps in predicting the intra and post-anesthetic course of the patient. It also serves as an aid in making important decisions during the post-anesthetic care of patient, like administering other analgesics and supplementing with sedatives. It also serves as an aid to the next anesthesiologist as to find out any complications even days or years later after this administration of anesthesia. And it also serves as a useful teaching device for the postgraduates and the residents, or as a demonstration and a source of information at a case presentation conference. And it can help in being a great valuable research database for retrieving information and doing many retrospective analysis and studies. And most importantly, in the court of law, it serves as a medico-legal document. So if an event is not recorded, it implies that it is not done. And lastly, it can also be act as a source of financial information regarding billing purposes as to what drugs have been used intraoperatively and how much was used. So what are the types of anesthesia record? They're broadly divided into two types. One is manual and the other is computer-based anesthesia records. So the computer-based have various terminologies for them, like automated anesthesia record keeping, anesthetic information management system, electronic anesthesia record, and computer-based patient record for anesthesia. So of these, the anesthetic information management system is the most commonly used terminology, and we'll be using that in a further lecture. So this is an example of our modern day manual anesthesia record. As we all know, most of our anesthesia records have blank boxes to check in and blank spaces to fill out with specific information pertaining to the patient. So careful filling up of this form itself guarantees a more nearly complete anesthetic record, and very little information will be left out on careful filling of this form itself. But still, there are many limitations for a manual anesthesia record. The first of this includes recall bias, where the anesthesiologist has to deliver patient care and also record data simultaneously, which can result in not accurately remembering a past event or leave out important details about them. And this delay in recording can obviously result in dilution or missing out of critical events. And the records are often illegible or difficult to read. Sometimes there is insufficient space to fill out, and they may be lost or be otherwise inaccessible. And because of all these reasons, there is always less medico-legal protection. So next, coming to computer-based anesthesia recording. So the concept of automating the anesthesia record has been in the thoughts since the 1970s, and many academicians believe that it has more accurate data recording when compared to manual recording. So, and the less need for manual charting during times of crisis and other busy periods of anesthetic care also requires computer-based anesthesia recording, and it has a centralized display on which all data, either the current data and the trended data, are available on one common screen or other display. So this is an example of the computer-based anesthesia recorder, which is linked to the anesthetic workstation, and information is derived from the anesthetic workstation. So it offers robust real-time second-to-second recording of data, and it can help in achieving paperless hospitals. It obviously saves a lot of time, and online entry of drugs administered can be done so that it can be easily billed in the pharmacy. And most importantly, the data is easily retrievable. That is, the device allows usage of either a USB device or an SD card, from which the information can be easily retrieved, or you can take a legible printed record of all the details at the end of the case. So coming to anesthetic information management system specifically, the core of the aims is the automated anesthesia record. But apart from that, some information still requires anesthesiologist manual input, such as the dosage and the name of the medications that have been administered. But other physiological variables such as end-tidal gas concentrations, arterial blood pressure, pulse oximetry will be automatically imported from the physiological monitor throughout anesthesia. So this is the anesthetic information management system, the anesthetic workstation, and the physiological monitor. So both of these are linked to the AIMS system, and data is being continuously imported. So AIMS is not a standalone system that only provides automated record keeping. Rather, it interfaces with multiple systems in the hospital, which can incorporate other anesthesia related data such as laboratory, pharmacy, and scheduling systems. So this is an overview of the anesthetic record, electronic anesthesia record, which contains almost all the information pertaining to the patient. So starting from the patient's name, age, height, weight, and the intraoperative drugs used, and the anesthetic gas concentrations used, including the vital signs like SpO2, heart rate, EtCO2, respiratory rate, and all the ventilatory parameters like the tidal volume, frequency, the peak airway pressures, and the PEEP. So the following few slides will contain an overview of an electronic anesthesia record and what all information has to be entered. So this is the first start of an electronic anesthesia record. This contains basic information pertaining to the patient, which includes patient name, gender, age, weight, height, including pre-op vitals and the ASA score, along with the NPO status. Along with this, other information like the timing of important events have also to be entered by us. This includes the start of anesthesia, end of anesthesia, the induction time, and the intubation time. So the next page leads us to the past history of the patient. So this includes all the past medical history, anesthetic history, surgical history, any history of allergies, along with all the pre-op investigations and airway examination. And this also includes the plan of anesthesia to be mentioned. And coming to the next page, so this page will ask us to specify the type of anesthesia which we are planning to administer. So this contains a list of all the types: general, epidural, spinal, local, and other types of anesthesia. In case of general anesthesia administered, what is the ventilatory mode to be used? What is the ET tube used, and what is the size? And including the vascular axis, what IV cannula and in which extremity is present, and what is the size of the IV cannula used. Then comes the list of drugs which are administered to the patient. So the drugs along with the dosage administered have to be entered, and any IV infusions if used and IV fluids used have to be entered by us. Rest of the parameters like the anesthetic gas concentration, inhalation agent concentration will be derived from the anesthetic workstation itself, and all the physiological monitors also will be derived from the multi-para monitor. So this is an overview of all the drugs used and the inhalation agent anesthetic concentration throughout the surgery. So this is again an overview of the entire surgery. It gives an idea about the patient, the type of anesthesia administered, what ET tube was used, and what was the Malampati grading, and details on the IV cannula, along with all the drugs administered and the inhalation agent used. So this is the overview of the overall trend of the patient during the entire surgery. It contains all the information like the end tidal anesthetic gas concentrations, the tidal volume, peak pressures throughout the surgery, and all the vitals like heart rate, EtCO2, BP, respiration, oxygen saturation, and temperature throughout the surgery. So this chart gives an overall trend throughout the anesthetic administered. So the next few slides will contain some articles published regarding audit of anesthetic records. So the first article was done in, the study was done in South Africa, which included an audit of all the manual anesthetic records. So this revealed that less than 1/3 of all records was complete and legible. That is, only 30% of all the records was complete and legible, whereas the remaining 25% had no record of any anesthetics used, and the remaining 45% were all incomplete or illegible in some or all respects. So the next study is based on the comparison of automated and manual anesthesia record keeping, which is a video observation study analyzing anesthesia related tasks. This revealed that manual anesthesia records had an overall timing of 22.6% for recording anesthesia, whereas automated anesthesia had only 12.7% of that time. So the direct patient care increased from almost 30% to 35% during automated anesthesia, and the washing surgery also increased from 7% to 9.5% in automated anesthetic records. Again, this is a study conducted in India in NIMHANS, Bengaluru. This was done to assess the completeness of manual data recording in the anesthesia information management system. As told already, certain information like the patient demographic details and the timing and duration of surgery have to be entered by the anesthesiologist itself. So this study was done to assess the completeness of those data, which again proved that even after 1 year of its implementation in NIMHANS, the completeness of manual data recording was still poor. So certain variables like the first case of the study, entry by a trainee anesthesiologist, and entry during elective cases were associated with better completeness of manual data recording in the AIMS. So what are the limitations of AIMS? For data that are measured, confirming their validity is important. So any data that is measured has to be converted into knowledge before assessing its importance. For example, value of SpO2 of 75% showing in the anesthetic information management system does not have to necessarily mean hypoxia. Value of systolic blood pressure and heart rate, which is normal during that time, and which shows adequate ventilation, most probably could mean that there were some artifacts in the pulse oximetry. So a clinical examination or observation of this could aid in better diagnosis rather than just looking at the data. So for any data that is measured, confirming the validity is very, very important. And then again, usage of computers requires proper training, and each individual have their own different learning curve. And as already said, it is not completely 100% automatic. Some information have to be entered by us, which can be cumbersome at some times. And it requires higher cost for installation, and it can again reduce patient interaction. As anesthesiologists, we already have very less patient interaction. Entering the data during the pre-op time can increase the patient's anxiety sometimes. And lastly, smoothing of data is not possible when it is electronically recorded. It can be perceived either as an advantage or as a disadvantage. So finally, the take-home messages are the duty is bound to care for the patient and to record all the important events. Keeping records is very, very important. Optimal recording of events is required for accurate treatment. So if you did it, write it down. If you don't write it down, it means that it didn't happen. From the medical legal point of view, courts will always believe more in what we have written than what we have to say. So finally, I thank my HOD Dr. Shanta Parthiban ma'am for guiding me through this presentation, and I thank Dr. Meenakshi Sundaram sir for giving me this opportunity. Thank you, everybody.
Thank you, Priyadarshini madam, for your nice presentation. And we will have question and answers at the end of the third session. Now I invite our most beloved person in the ISA, and he is Dr. Venkatgiri. I hope Dr. Venkatgiri is there. Venkatgiri sir.
Deshpande sir, let the question answer be over. I will just join. Let the question answer be over. There are two topics. Then I will join. These two topic question answer. Madam is ready there. Is also ready. Yeah.
Okay. So let us go for the question answers from the audience about the Sugamedics and the anesthesia record keeping. Swami sir, are there any questions in the chat box? Swami sir.
Sir, yeah, there are some questions from in the chat box.
Yeah. So you can go on asking about these two. So that's either they will answer or somebody from the audience will answer.
Is it possible, Dr. Dilip or Dr. Priya ma'am? Can you? I think Dr. Dilip, you can see the chat box.
Yes, ma'am. Definitely. I see the question: how do we re-establish neuromuscular blockade after Sugammadex administration, and whether it is, if it is an emergency case, and can Sugammadex cause residual paralysis in post-operative period? Okay. So first thing, to re-establish neuromuscular blockade after Sugammadex administration, two things has to be kept in mind. One, the dosage of Sugammadex administered at the first place, and the time after which after the Sugammadex administration. So the recommendation says that it is better to use other group of drugs like benzyl isoquinol in satracurium or cisatracurium, or even saxamethonium can also be used if a situation arises for re-establishing neuromuscular blockade, or if you are persisting in using rocuronium itself, the dosages of around 1.2 mg per kg is needed, then at least duration of 5 minutes is needed from the first administration of Sugammadex administration. And if you're trying to give rocuronium at a dose of around 0.6 mg per kg, then a duration gap of at least 4 hours is required from the first time of administration of Sugammadex. And the second question what I got is, can Sugammadex cause residual paralysis? Yes, definitely. Sugammadex, it can cause residual paralysis, but when compared to neostigmine, the rate is very less. The residual paralysis is mainly because of the reduced dosage. The adequate dosage will not be provided, will not be given. Probably that will be the reason for residual paralysis. So coming to the third question here, the trade name for Sugammadex. Yeah, the Sugammadex in India, it is manufactured by BDR Pharmaceuticals along with Varanium Hospital Care. They are the manufacturing company. It is available as Sugmadex. That is the trade name. Sugmadex is the trade name. And the cost, the 2 ml vial cost around the 1,400 rupees, and the 5 ml vial containing around 500 mg, it may cost around roughly 4,500 to 5,000 rupees. So my experience in using the drug, well, at present I have not yet used the drug, but many efforts have been made by our beloved HOD sir to introduce the drug in our department for our use. Very soon we will be using it. Thank you.
You talked of just now about the residual paralysis.
Yes, sir.
or it may be reparalysis also. We don't know exactly whether it is residual or it is reparalysis.
Yes, sir.
Right?
Yes, sir.
But, as far as the properties of this drug goes, it is almost nearer to the ideal reversal agent.
Definitely,
As you
sir.
also said that it immediately reverses the actions of the rocuronium. If you
Yes, sir.
increase the dose of it, you intubate it, you give rocuronium, you again can reverse the action of the rocuronium. But still,
sir.
this reparalysis or say less recovery from the drugs. Is there any reason for that?
Probably, sir, the dosage of rocuronium given, if the dosage is given as like around 1.2 mg per kg, and the Sugamadex given is less, like in the dose of 2 mg per kg, then that might be the reason for residual paralysis, sir. Adequate dosing is important.
Yes, and you have to be very sure that you are not using it in the persons, and especially in the females who are on contraceptives.
Yes,
One
sir.
thing.
Definitely.
The contraceptive itself utilizes the units for that, and then it does
And
not
also,
cause
as I said, there is one more. Yes, sir.
reversal of that. You have to be very sure about it. And the second part, it has got certain actions with the verapamil also.
Okay, sir.
It has got certain actions with the verapamil, maybe blocking actions, or maybe some adverse reactions, or whatever it is. Do you know what is the meaning of this Sugamadex?
Definitely, sir. Sugamadex, the word su refers to sugar, and Gammadex is nothing but the gamma dextrin. That is a chemical structure, sir.
Chemical structure. And who invented it?
It was invented by a scientist from Scotland, sir. Organon Institute. So it's also called as ORG 25969. Yeah. Organon was
very famous for the pancuronium. Previously, the pancuronium was used to be manufactured by Organon only. It was not available in India. When I think I'm talking about 82 or 83 or 84, somewhere at that time, we had to import that drug from Holland. And it was very rarely used, or it was kept in the lock of the HOD. And then you had to get the key and get it out of that. So same Organon fellow has did it, and really a wonderful drug. It is near ideal reversal agent. But one of the quality of that is not there when we say that the qualities of the ideal reversal agents, which are the one is the fast onset, second is efficient at any time, as I already said, even if you intubate and you can reverse it. Third is complete recovery. That is one of the character for that. Fourth is the longer half-life than the muscle relaxant itself. If it has got a longer half-life than the muscle relaxant effect, then it is the most ideal reversal agent and no side effect. But this drug is closer to the side effect. So I think it is much better than any other drug which is there. But looking at the cost of it, somebody has to move the mind from that using it, isn't it? 4,000 rupees, 5,000 rupees for 5 ml, 2 ml is not possible everywhere. But sometimes in the institute it is possible, yes. But as you said, if there is a reparalysis, you should not use the same type of drug again. You can use another drug, right?
Yes.
You should cut some. That's the correct point which I noted it is. Any other person from audience wants to ask any question about it? Or we'll move to the second topic then. It seems that there are no other questions from the audience. Thank you, Dr. Dilip Kumar. You mentioned it very nicely. And it was a very good collection of your all of the content in your talk. And you presented it very boldly. And I must thank Pudukkottai that they are giving chance to the senior residents to talk over here. So that they develop. Good evening, sir.
Hello.
Good evening. Hello, sir. Good evening. They develop the habit of.
Good evening. One question on Sugamadex from me. Can I ask?
Sir. Yes, sir. Yes, sir. Why not?
No, can we use in, and he was told that renal failure, because when in a renal failure, what we do is we use etracurium, because elimination law. Can we use curanium in renal failure and use Sugamadex for reversing? Is it possible?
No.
Just for a theoretical this thing, not other thing. Just is there?
Come on, say it to sir. You have answered it already in your talk.
Pardon?
Sir, sorry, sir, I didn't get the question.
See,
breaking.
We use etracurium for renal failure patient because for renal elimination. Here, if you use rocuronium with this thing, even where there is with the higher dose or maybe the double dose, we can totally reverse that. Can we do it in renal failure cases? Patients use rocuronium and reverse with the Sugammadex. Is it possible?
No, sir. Rocuronium with Sugammadex in renal failure, it is better to be avoided, sir. The recommendations clearly says that if the creatinine clearance is less than 30 ml per minute, it's not recommended, sir. Definitely not recommended, sir. Even though it can be used, the efficacy might be the same, sir. It does its action. It goes and binds the Sugammadex molecule. It definitely will go and bind the rocuronium. It might reverse the neuromuscular paralysis at that moment, but the complex, it still remains in the body, sir. So there might be chances of recurrenization sometime.
Okay.
So better to be avoided in patients with renal failure.
Okay.
So elimination of the complex is reduced. Elimination of the drug is reduced.
Yes,
right?
sir. Yes. Elimination of the complex is reduced, sir. Yes.
Sometime, and it may get reverse effect also again. So better not to use that. You can use something else other than Vicodinium for.
Yes. If it is used, then definitely dialysis, hemodialysis can be done for removal of the complex of Sugammadex and rocuronium, sir. Hemodialysis might help in those patients, sir.
We are the cost of it every day. 4,000 rupees dialysis, 5,000 rupees for one part. Yes, better use other drug. Better use other drug, safer drug, other drug. Yes. Yes, sir. Venkatgiri, sir, should we finish this Priyadarshini's question answers and then we go for your talk? Hello?
We will finish, sir, and then we will go. Yes, yes.
Yeah. Dr. Priyadarshini, you have presented the anesthesia record keeping very nicely. No doubt about it. You studied it very well and you had a deep study about it. You had good pictures of the airways and everything. And I would say one thing, that even most of the places we keep the manual records. Say 30% places we are keeping the computerized records, but 70% times we are keeping the about manual records. And one of my experience, when I used to tell everybody that whenever you are handovering the patient from say our recovery room to the wards, I always used to ask my resident that whenever you are taking the patient to the wards, please see all the vitals there in the wards, mention them on the paper, and ask that sister in charge to check everything whatever you have written, and check the vitals which are there, which you have written over here. Then only once it is over. Otherwise, what happens if something goes wrong in the ward after 15-20 minutes, they will contribute or they will finger towards anesthesia system only and nobody else. So this is the system which I had developed and kept in mind, and all my residents and all my co-workers also. Even in private, when I used to do, I did 40 years of my freelancing. Even in private, I had a record of most of the cases. After 5 years of my practice from 1987, I kept the record. Even today, I keep the record. And I had a record books which I used to write manually. And it is like a receipt book. Every page has got a record of one person. And I used to take the signature of that sister who is there in the ward, even in the private, that everything is okay and patients monitors and the vitals are here like this. So that I have to run to other place somewhere for the case. And then I am very safe in that particular part. So it is my request to everybody that please keep the record, even if you are doing the private cases. Because nowadays, there are so many things which are happening in the anesthesia systems. And any drug gives any type of reaction at any time. When you have received it so many times, still you get the reaction. So it is better to keep the records every time. Any other thing? Anybody wants to ask any other thing about this record keeping? And you said a very good point, Priyadarshini, that if the computerized record is there, validity you have to confirm of that record. You have given an example of the SpO2 which was 70%, but all other physiological parameters were not confirming with the SpO2 70%. So there must be some problem with the fingertip or whatever it is, or the instrument itself. So it is better to be like that. Yes.
Yes, sir.
Anybody from the audience wants to ask any question to Priya?
Sir, Dr. Meenakshi Sundaram.
Yes, sir. Yes, sir. Yes,
Yeah.
sir.
Yeah, the same thing. Even 10 years back, I voted against computerized record keeping. That is, computerized record keeping means they say after that NIBP monitor is, the case is over, you take a printout from a multi-parameter monitor and keep it in the case sheet. I said it is not possible because if the probe has moved out, it will record as 0, the SpO2. Then the court of law may say you have failed to do that. So then and there, if you are pasting for sake of convenience, if you are pasting the paper, you please record this is only this thing. No untoward event has occurred. But she has presented very nicely as chairperson has pointed out. Too
Yeah,
good.
yeah.
It
About
is
it, sir.
too good. People are
And
waiting for
no,
SARC president lecture.
sir, one more sentence. I appreciate that her guidance was very good, given
Yeah.
by her madam about the preparation of this topic. It is very good, really
Yes,
very
good.
good. Thank you, madam. And she had
Congratulations.
Actually, I could not attend because there was a phone call from abroad.
Sir, we will send the recording, sir. We will
Okay.
send the recording,
I'm
sir.
very much interested in keeping the records, but I
Yeah.
keep track of the.
We will send the recording.
Thank you,
No
Amma.
issues.
Thank you, Giri. You should have started it. Okay, welcome, Giri.
Sir, Giri sir, yes, you can start your topic, sir. Please, Giri sir. And sorry, you had to wait for 10 minutes. Giri sir, welcome to this particular.
Okay, thank you. Deshpande.
Yes, sir.
Good evening, President, Secretary, ISA Pudukkottai, Dr. ALM, Dr. Deshpande, my co-speakers, Dr. Chakrarao and others. Greetings from ISA National. Slide is not moving. Shilpa,
not
slide is not moving.
ಸರ್ ಒಮ್ಮೆ ಅದ್ರ ಒಳಗಡೆ ಕ್ಲಿಕ್ ಮಾಡಿ ಸರ್ ಒಮ್ಮೆ ಒಂದು ಅಲ್ಲಿ ಒಮ್ಮೆ ಕ್ಲಿಕ್ ಮಾಡಿ ನೆಕ್ಸ್ಟ್ ಇನ್ನು ಮೂವ್ ಆಗ್ತದೆ
Okay, right.
It has moved.
Right. The topic is on medication error or anesthesia drug mishaps. So it has gone to the next slide. Okay. A medication error is any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in control of the healthcare professional, patient or consumer. Such events may be related to professional practice, healthcare products, procedures and systems, including prescribing, order communication, product labeling, packaging, nomenclature, compounding, dispensing, distribution, administration, education, monitoring and use. So there is a long definition on anesthesia or any medical error. If you go to the statistics, that the 2008 WHO shows that complications after inpatient operation, 25% of patients. I think whether that much is there, I don't know. The statistics shows that WHO statistics from the Safe Surgery Save Lives from 2008. And the crude mortality rate after major surgery is 0.5 to 5%. And half of the adverse events, even in advanced countries, are related to surgical care. And most of them are preventable, at least 50%. And they are due to surgical causes and preventable. And this happens even in tertiary care hospitals. But mortality in anesthesia is very, very low now. Earlier, it was 1 in 2,500 to 5,000 before 1980. And now, after widespread use of ETCO2 and SpO2, it has reduced drastically and has come from 2.1 to 1 per 10,000. And as on date, it is 1 in a lakh in advanced countries like Australia, Europe, and USA. The morbidity data also show it is solely due to anesthesia is very, very uncommon. But it can happen, and there are some incidences are there. Minor anesthesia related perioperative events are 18 to 22%, and serious complications are hardly half to 1.5%, and permanent damage is just 0.2 to 0.6%. Sir William Osler said, error in judgment must occur in patients in practice of an art which consists largely in balancing probabilities. So if you are doing good number of it, there may be some errors always, even if whatever care you take. But when you say that drug error, it is a failure to give a drug or dose or drug that was intended to use. And there is another pre-error where we do not give the drug If it was given, there would have been an accident or some problem would have happened, but it did not happen. To err is man or to rest human, as anesthesiologist, we may be injecting large number of drugs. It is seen that at least 500,000 different drugs an anesthetist injects in his professional tenure. And the chance of making an ignorant error is a little, but still it can happen. And when patients consent for anesthesia, they trust on you or me, thinking that our treatment is adequate, our training is adequate, our judgment is uncompromised, and competence is validated. And the research has studies shown that about 2 out of every 100 inpatient experience preventable adverse drug event, and medical errors should be a priority as an urgent, critical, and widespread public health problem. These are the incidences. Statistically, the drug error percentage comes from 0.078 to 0.75% from different studies. And most of this thing among the medical related errors, the second biggest is medication error. Historically, a system failure that has profound implications of anesthesia in United Kingdom was the case of Woolley and Rowe, in which 2 patients were left paraplegic after undergoing spinal anesthesia in Chesterfield Hospital, Royal Hospital in 1947. That time, for sterilization, the spinal ampoules were put in phenol and thought that it is due to phenol which is creeped into the bottles through the small crevices. And the fatality reported when the flow rate of patients epidural, that was the nurse, instead of giving IV fluid, gave the epidural infusion at the rate of 125 ml per hour by the ward nurse. These are the adverse events which happen. And how and why these errors occur? They are multifactorial. It can be human error or other errors. Among human errors, it may be anesthetist or anesthesiologist, surgeon, the assistant nurse or the technician, or even the patient factors. It may be drug. Drug means it may be look-alike, same brand name but different chemicals. You can't read because as per the Drug Act, you should print so many letters in that thing, and if it is such a small letter, we can't read even with the large magnifying glass. Then mechanical, like electricity failure or poor light. Just in the nick of the time, you don't get, the power has gone, there is no UPS and no this thing, you have to inject the drug. It happens exactly when the baby is expected, you have to give pitocin and this thing. And the other one is overconfidence. You think that, yes, I can do that and I will be managing. Assistance or self. The syringe swab, it may be labeled or unlabeled. Wrong drug given due to poor vision or uncolor coded. Hurry. You are in a hurry. Gynecologist telling that the uterus is not contract, give. In that hurry, yes, you give look-alike another drug. And not checking the drugs. You over rely because many times we see that the color of the label and see that, yes, this is the drug. That is it. Remember drug addicts as your assistant. There are many OT technicians who are drug addicts. You should be very careful. Because I know that that person in one of the hospitals, he was taking the fortune from that ampoule and putting atropine into that. The anesthetist gave fortune to sleep, and again only pulse rate was increasing, pain was not reducing. These are the things you should be very careful about that. OT technicians or nurses, there are a lot who are drug addicts. Professional rivalry, that is also there. People may put, because many hospitals, they don't use many anesthetists, they don't use the vial which is opened by somebody, but use only always fresh vial, fresh sample, because somebody if has put something else into that vial, no, because professional rivalry. Ignorance, poor knowledge and skill. Causes. The wrong medication is 48% cause for the drug error. Overdose in 38%. Incorrect administration route, 8%. That is, instead of giving IM, you give IV, because especially this when gynecologist says the uterus is not contracting, instead of giving intramuscular carbostol, you give it IV. What is this thing? We do not know. That sisters have given that. We do not know what is that. They have put in IV drip, they have put direct IV also. Underdosing, not giving the correct dose or omission to give a dose. Opioids, cardiac stimulant and vasopressors are most common culprits in drug error. Then 42% of the drug medication administration occurred following syringe swab. because you keep two syringes side by side, and because when I studied, there was one principle that we had three syringes, 10 ml for pentothal or thiopenton, 5 ml for relaxant, what we used that time was a Pavilon or a DTC, and the 2 ml syringe was the scoline, succinyl choline, because we can't error, that should be there. After using that 5 ml syringe kept in the reverse direction for giving the reversal. This was the practice which used to do that. Drug ampoule swap occurred in 33% cases, because many drugs, I will show the picture, they look alike and you do not know which one you are giving in a hurry, or maybe even with the good light, many times you can't read that. And wrong choice of drug was made in 17%, because you do not know which drug, whether you give etracurium or vecuronium, which drug we do not know. Wrong drug choice was given and it led to the problems. Fatigue, tired and sleepy, because you are always on duty. If you see PGs, it is 36-hour duty. Maybe on duty you are start today to tomorrow afternoon. You should be tired and sleepy. Distractions. Yes, today was the budget day. Morning, yes, you may be interested in hearing the budget or the stock market, know what is happening. Distractions will happen. Then others, yes, mobile phones, somebody sitting there, or you are relaxing. And next is anaphylaxis. You should be always, it is not a wrong thing or this thing, but drug error can happen due to anaphylaxis. Whatever drug, it may be antibiotic, it may be your muscle relaxant. It is not an error, but it is very important that we to prevent morbidity and mortality. Intraoperative drug reaction, they may be life-threatening, and we should be very, very careful. And when it happens, because sudden fall of BP, or you may not be seeing any reaction, but like goose skin or but BP fall or something will happen, and you should be very, very careful and start an emergency procedure. 50%, 58% of the NRD events occurred in the OT, and 3% were before induction, 81% after induction and before surgery, 13% during surgery, and 3% of these are the statistics shown that how much is that. And during anesthesia, anaphylaxis, it is 1 in 10,000 to 1 in 20,000 procedures, and among neuromuscular blocking agent, it is 1 in 5,200 to 1 in 6,500. Other things are, I will skip this slide. What are the high among the muscle relaxant? High risk is rocuronium. Natural latex is another one which can cause reaction. Antibiotic, penicillin, cephalosporins, hypnotics like propofol or thiopenton, colloids, dextran and gelatin, opioids, morphine and pethidine, and other substances like contrast dyes, analgesics, and thing can cause drug reaction perioperative period. Medical legal aspects. This is from the NHS UK. 93 claims. Cost was 4 million odd. That is 49 lakhs 15,450 Great Britain pounds filed for anesthesia mishap claims, and it was between 1995 and 2007. And among that, 62 claims were involved elite drug administration, and 15 resulted in severe harm or death. Half the elite administration of due to wrong drug. In most cases, it was neuromuscular blockade, and 9 were elite opioid overdoses, including neuraxial route. The most frequent recorded adverse outcome were awake paralysis, because without giving thiopenton or this thing, given the relaxant, and 31 claims involved allergic reactions. If you classify medication error, it can be near miss, slip, lapse, medical error, medication error, adverse drug event, or preventively. Near miss is the occurrence of an error that did not result in a harm. Slip is a failure to execute an action due to routine behavior. Lapse is failure to execute an action due to lapse of memory or routine behavior. Medical error is failure of a planned action to be completed. And medication error is the error of medication process giving the wrong drug. Adverse drug event is an allergic reaction to a drug. And preventable adverse drug event is harm that couldn't have been avoided through reasonable planning or proper execution. There are medication error index that is called A to H, the classification that A is the category A circumstances or events that have the capacity to cause error. Category B is an error that occurred, but that error did not reach the patient. That is error or omission. It would have happened, did not reach the patient. You did not give that. You have loaded and kept ready, but did not give. Category C is error that occurred that reached the patient but did not cause any harm. You might have given a smaller dose. You have loaded and given the drug, but maybe halfway through you stopped that. You gave the little smaller drug. Category D is an error occurred that reached the patient and required monitoring to confirm that resulted no harm. So you have given something, but it did not cause any harm. And E is an error that may have contributed to the resulted, may have contributed to or resulted in temporary harm or patient required some intervention. Category F, an error that occurred that may have contributed or resulted in temporary harm to the patient and required initial or prolonged hospitalization. Category G is an error that occurred that may have contributed to or resulted in permanent patient harm. H is error that occurred that required intervention necessary to sustain life, maybe giving a ventilator or so. Category I is resulted in patient death. So it is categorized from A to I. The classification error during anesthesia is errors during preparation of the drugs, administered drug, or recording of the drug delivered. Preparation is that similar looking drugs or ampoules are placed together, but they are unlabeled and you give the wrong drug. Administered drug is a near miss, wrong patient identification, incorrect dose or inadequate dose or excess dose, especially in pediatrics, and different person for preparation and administered drug. Syringe swab are this. Recording adverse event is not recognized and reluctance among us to administer or admit the error and record it. Unsafe acts, that is the slip or lapses of the rule or knowledge based mistakes, violations of others. Local workplace factors, there are a lot of workplace factors. You are in a new place, the rules are different in different places, administration is different and the supervision different. So you may be. Organizations at the high level strategic decisions. Standardization, technology, pharmacy and culture, I will skip this. The recommendation related to avoidance of drug error and drug administration in order to strengthen our label on any drug or ampoule or syringe should be carefully read before a drug is drawn or injected. This is strongly recommended because whatever this, you have to read that label, which is either printed or which you have labeled, and you have to read it before giving any injection. Legibility of contents of the label of the ampoules and syringes should be optimized according to the agreed standard, because whatever you write, handwriting of doctors are very poor. You should write it legibly, or printed labels should be printed to any drug which is loaded. Syringe should be labeled very properly and it is strongly recommended. Formal organization of drug drawers and workspace should be used, because see, whatever is the now with the NABH, there are so many rules that you have to keep the drugs in this place, not in the OT trolley or so. You have to use that wherever the drug is used, that should be used as it is. Label should be checked specifically with the second person before the drug is drawn up or administered, because once you see that, okay, thiopenton, show to the other one, or many places they have that. Giving thiopenton, giving thiopenton, check two people. They say that maybe in the freelance or busy practice, I don't know how much it is practical, but it is the recommended practice. Errors in IV drug administration during anesthesia should be reported and reviewed, because whatever wrong thing done should be recorded and reviewed, because we are not doing that. That is recordically you have to do that. It may happen, but you have to tell that, yes, this happened for this, I have done this. Management of drug inventory, that is also very important, because we do not know drug inventory means because first come first serve or nearest expiry first out. You have to, many times the drug which is remaining in the back of the drawer will be remaining. New drugs will come in the front and you will be giving the date expired drug, because see, you see one drug, okay, it's given the previous one which goes on there in the stocks in the behind. Similar packing and presentation of drugs, they should be avoided. There is always, I say that, okay, this color, Whatever one brand is used, use the same brand. Don't use these brands, different brands to prevent. Drugs should be presented in pre-filled syringes is far better than that we are loading them and giving them. Drugs should be drawn and labeled by anesthetist who is administering that anesthesia is possibly recommended, because not somebody, because not your technician. If you are giving anesthesia, if you only draw and then you know that what is being done, how much you loaded and this thing, not the others. Color coding, already told you. Coding by syringe position and needle. That's also what thing is, see, as I said, 2, 5, 10, this 2 seeing for scolin and 5. See, if you have that practice, always you know that, yes, this syringe is for this drug, 2 ml, 5 ml, 10 ml, and giving the this reversal syringe, the reverse direction. If you keep that, if it is a practice, you will never miss that. So this is the look-alike. One is dexamethasone, one is glycopyrrolate. Almost look same. What you give in that? These are different brand companies. The color coding is also just like glycopyrrolate, the other one. Glycopyrrolate also is the wrong color. It should have been green. It is given in that color which is used for neuromuscular relaxants or for the sedatives. Dexamethasone, you may miss that. Furosemide and midazolam. See, it's the same color, and that color which you use for midazolam is used for furosemide also. Instead of furosemide, you may be. It happened in one of the hospitals. The surgeon, ophthalmic surgeon, told the ward nurse to give midazolam 2 ml before shifting the cataract patient to the OT from the ward. She gave that and called the doctor and told her patient is having convulsions. Before the duty doctor and others did, patient died. What they gave was scolin instead of this. Both were looking similar, color coding, and this nurse gave 2 ml of scolin instead of 2 ml of midazolam for sedation, and patient could not be revived. Lignocaine, both look similar. See, midazolam scolin, as I said, looks similar, and if the cap is removed, and many times after some days, when you keep in the fridge, the color may not be there. You may be thinking, okay, this is the color. You will be giving that. The other one is clonidine and oxytocin. Both are similar. The ampoules. The ketamine and mephentermine. See, both are similar. You may not. There is a government supply ketamine and government supply. Other one is government supply mephentermine. So these things look similar, and by advertently you may be thinking that okay, your practice both are kept together. You may give. See, 4 ampoules look similar: pentazocin, atropine, tramadol, and oxytocin. You may be by mistake giving one drug to another. These 5 vials: scolin, midazolam, mephentermine, ketamine, and other one is dexamethasone. All look similar, and once the top is removed, so you may be missing sometimes. And if it's a new vial, okay, when it's for some time, the color may not see that. 2 drugs, same brand name, but content are Medzol. One is pantoprazole, another one is midazolam. You say that give Medzol. Which one to give? IV fluid. Once it is over, air is going through that. So for how you prevent proper color coding, propofol, that induction agent in yellow color, atropine or glycopyrrolate, green colored ampoules, the muscle relaxant vecuronium, that color orange colored, vasopressor, see black letters. So what we have to do is we should be very careful, and then we can prevent this drug action. They are bound to occur. One cannot eradicate them completely, but you can only prevent them to a certain extent, and above all, be prepared to face them. It happens, you have to be prepared to face them. For that, what you require is eternal vigilance. Routine anesthesia practice is a complex collection of mental and physical activities in an efficient management of routine cases rather than management of life-threatening crisis. But expertise is anticipation, prevention, and management of such crisis. We all have the ability, but have difference in how we use it. We should be experts in managing these situations in the crisis, and then we and they're bound to occur. If it occurs, what to do? Admit it first. If possible, prevent and manage if you can't prevent. If it happens, definitely it will happen one or the other day. Never feel guilty because it will happen. It has happened with other person also, me also, you also. You have to manage it. Don't panic. Call for help immediately. You have to assume the role of a leader. Reason and judgment are the qualities of a leader. You have to reason why you are giving, how you give that, and how to go ahead. Call for help. Let others also come. They will help you. You should have a teamwork to do this. If you have others, yes, that's because one person may not be able to do that, but you need somebody. And in that, you should have good communication. You should say what you mean, and you should mean what you say. And prioritize the steps in this management of any adverse event which happens, or drug reaction, or if not happens. Assign specific jobs to specific individuals and declare an emergency. There is no place for any ego or telling that everything is okay. First priority is patient, and he is what is right for the patient, not who is right. For that, you have to use written protocols. Every hospital has written protocols. How you have to do, what you have to do, and all. Turn off all anesthetics in use. Make 100% oxygen. Maintain oxygenation at all costs. If in doubt, airway and oxygen supply, ventilate and have backup supply. Ensure the patient has good pulse and BP is in acceptable level. Commence ACLS. Document every event earliest time possible and make summary of the event. So, in that, what will happen is in the triggering events, it may be equipment, or how you prevent is in prevention. If it is equipment, it may be design flaw, man defect, or maintenance failure. You have to do a pre-checkup. Patient, he may be having underlying disease, he may be taking drug, or he may be allergic. You have to do a pre-anesthetic checkup. Among the anesthetist, surgeon, or nurses, there may be production pressure or fatigue or environmental factor, because especially in the corporate sector, you may be there may be target, you have to do this much and all, how you will do that. But you should be very, very careful. Use your care and skill, presence of mind, and ability to cope with it. If it happens, recognize and manage, it will be recovering completely. If unrecognized, lead to a critical event, still unrecognized, it will go to adverse event. Recognized and treated, patient will recover either completely or partially. Prevention is always better than cure. So, don't drink without seeing it, and don't sign without reading it. So, when you use an anesthetic drug, when you are giving to somebody, always read it properly and then only give that drug. The mistake which I have shown, that I showed my own photos for that, see, not wearing the mask and doing that. A man who doesn't make mistakes does not do anything. He is just sitting idly. Mistakes are done by everybody, but we have admitted. Anesthesia also must be leader and never give up. Whatever it is that, yes, we should hold and try to save that. A man who any man may make mistake, but none but fool will stick to that. If you are wise, you will learn by your mistakes and correct it. Thank you.
Thank you, sir. Venkatgiri, sir, thank you very much. And you had really put the facts about everybody, that adverse reactions can occur, adversely drugs can be given, and you have to admit that. That is more important, and learn from that. That is another thing which is to be learned from you also. And you had given a very good examples of the look-alike and sound-alike drugs. In one of your slides, you have shown that Sucol ampule. Yeah. And on that Sucol ampule, I have also that type of vial, which on that it is written for intramuscular and intravenous use. That I had written to the company also. But
I have ampoule of Bupivac AN written as intramuscular use. Ampoule of government supply ampoule for IM or intrathecal ampoule. I have kept that.
No, I am surprised that till this date, no general practitioner has came to know that this can be given for the muscle spasm. For intramuscular, it is written on the vials. Otherwise, there would have been a lot of casualties of that. I had written to the company also, taking the photograph of that, the bill for that and everything. But there was no response from them, not at all. And you had a very good presentation. And I had few of the things which I want to say about the wrong administration of the drugs, which I have faced in my life. I used to go to one of the nursing homes, and in that nursing home, we had a practice that our sister used to fill up the atropine, pentothal, and scoline. And when I used to reach the nursing home, they used to give atropine intramuscular to the patient. Because I used to sit 15-20 minutes there, chat with the surgeon, and then I used to enter into that room. That was the whole system. One day, there was a hemorrhoid of one of the doctors who was BMS or BHMS, I don't remember. He was practicing in the rural areas. And the moment that sister has seen, she gave the drug succinylcholine instead of atropine to that fellow, intramuscular. And after 10 minutes, she asked, after 5-6 minutes, she asked, go to bathroom, pass a urine and come back. So he went there and he collapsed there and there only. So she came running, that patient has collapsed there only. We went there. I immediately said she has given scoline instead of atropine. I intubated him. He was survived. He came out within 5 minutes. But after that, he never turned up to that nursing home. Neither he has referred any patient to that nursing home. So this was one thing. And another thing which I still surprised, that how the patient has recovered. It is one of the, what is that called as, one of the hospital nearby Sangli, 100 kilometers from us. And it is a free hospital maintained by one Devasthan. I used to go to there every Sunday. Every Sunday I used to go there. I used to do 5-6 cases free, no charge, nothing, and come back. Everything was there at that time.
Only Prasad.
I had to give a block to, yes, sir.
Only Prasad you are getting. Huh?
Yes, sir.
Because it is a Devasthanam, you are getting Prasad.
Near Sangli, and it is 100 kilometers. It is Gondavlekar Maharaj's Devasthan.
Okay, good.
So that is near Sangli, 100 kilometers, and everything is free there. All surgeries are free. All types of equipments are there. All instruments are there. I wanted to give block to other next patient. I have filled up bupivacaine, diluted, taken 5 cc, diluted to 10 cc. And one surgery was going on, that was finished. Inadvertently, I kept that syringe on the Boyle's machine. My colleague felt that I have filled up the reversal. He put it up and he has injected into the patient. 10 cc of the bupivacaine injected into that patient, intravenous. See what must have happened with both of us. But surprisingly, I don't know how the patient has come out and how he survived. I don't know that. But he survived ultimately. Possibly it is, nobody will believe. But because it is at the Devasthanam, so he has survived. Everywhere else, he would have just died of the cardiac depression. But it has occurred with me. And that day I was sitting there after that case for 2 hours, doing nothing. I was just observing that patient. And I cancelled everything and we came back that day. So these are the things which happen. And but I had to learn, I learned so many things from these things, that not to fill up the drugs before I go to the hospital itself or before I go to the OT. Not to pre-fill the drugs when the second case is going on. That I have learned and I have followed it. And every time I have followed it. So some of the things they happen. And nowadays, all of us knows that the NABH is going on in all the hospitals, private hospitals and the medical colleges also. And in NABH, there is one part is that you have to inform the ADRs, adverse drug reactions. There is a form for that, adverse drug reactions. You have to fill it up and you have to give it to the pharmacology department of your medical college. If you don't have it, you have to give it to the pharmacy which is there in the either civil hospital or in the private hospitals, so that they have to collect it if same type of reactions are occurring. In my hospital, one gentamicin was there. I don't know from which company, but after giving the gentamicin, almost 80% of the patients complained of the headache. That was filled up as an adverse drug reaction. And all the forms were sent to the pharmacology department. They have returned to the company. And ultimately, company has said that, yes, there is some problem with that product. They came to us, they have replaced all the gentamicin. So unless we inform it, and it is none of our fault. Mind well, most of the times it is not informed because we feel that it is our fault, that we had given gentamicin, but we give it every now and then. but every company gentamicin doesn't produce that. This company gentamicin has produced it. So we are informed it, and it is a must. And whenever there is a NABH inspection, they ask how many ADRs are reported from your hospital. And I think some points are there for that particular part also. So that it is better to inform such type of thing. And so Venkatgiri sir, you have shown one very good thing, that error index from A to I. I had not gone through the literature, and wherever I have gone, I had not seen it. But you are really enlightened us on that A to I index. And really very good presentation, nice one. Anybody, any delegates or any participant has got any questions to Dr. Venkatgiri?
I'm not seen in that.
There are no questions.
There are no questions or anything there. Because you see, it can happen with anybody.
Yeah.
20 years back, I had given adrenaline instead of atropine. Again, luckily it was a government supply. Nothing happened. It was a bradycardia. I just gave one ampoule, and that all ampoules are government supply ampoules. Old type ampoule looks similar. I gave that. Patient was telling heart was coming to his heart is coming. That's the word he used. My heart is coming up. What to do? I can only pray. There is no reversal for that. What is the reversal for? I asked many people. Adrenal you give inadvertently. Nothing.
Yes.
Just gave that one ampoule because it was a brady. He had two, but it was. I gave only one midazolam. I had the only thing that time midazolam was there. Nothing else was there. This is the thing. What happens?
And you said something about that it is difficult to read on the ampoules.
Yeah.
What is written on that? It is written in very small letters.
It is very, very small letters. Even in the magnifying glass.
I take a photograph of that in my mobile.
See,
and you can see what it is exactly.
Many times, if the letters are sharp, okay. If the letters are not sharp, very crumbled the letters many times.
You cannot, sir. You cannot. That is true. Better not to give it then and save yourself. That's the only thing.
What I say is, don't change the brand. I have the same color code. Because see, after that incident, I wrote in the anesthesia machine, green atropine, black adrenaline. I say that adrenaline should be like now. See, 3 days back, I opened adrenaline and pitocin together because they kept pitocin and adrenaline both together in the same box.
Yes.
I'm reading, yes, I can know, okay, these people have given that wrong, but luckily I did not load that. Again, I read that. Look, similar, pitocin and adrenaline. And nurses have kept both together in the same box.
Yeah.
So because we should be very, very careful. And
they had given a very nice term for that, look alike and sound alike.
Right.
Their pronunciation is also like that, look alike and sound alike. So you have to be very sure about that. And there is a rule that you cannot keep together the two things in the medical store of your hospital, look alike and sound alike. Yeah. They should be kept apart. They should be kept apart. That is a rule. And most of the times, whenever the NABH people come, they will visit the store and they will see where are look alike and where are sound alike. If they are kept nearer to that, then you got a negative marking in that NABH problem. Yes. So these are the things which happen, and we have to be really, really very careful about all these things. To be careful about that and save yourself and save your patients. I am coming to the last part of this now, and I am thankful to ISA Pudukkottai branch. Thankful to Dr. Suresh Kumar, who is the president of the branch, and Dr. Periya Swami, who is the secretary of that, Dr. David, treasurer for that. And above all, my best family friend is Dr. Meenakshi, ALM is known as, and Maharashtra says him our own Meenakshi. His designation is our own Meenakshi. Maharashtra says that. Thanks for calling me over here, and thanks for giving me the chance over here. And I'm thankful to Dr. Venkatgiri, who is a past president of ISA and academic chairman of the ISA, past secretary of ISA, present president of the SARC, and above all, he is a close heart friend and family member of my family. An excellent talk, sir. No doubt about it. Very good presentation. And I hope everybody has been enlightened on this particular part. Sir Chakrarao, sir, your comments are expected on all these things. Please, sir.
All the three topics are very good. Of course, I could not listen to the topic on medical recording.
Yeah.
They have done a wonderful job and collected a very nice material. And these are the talks actually. These are out of the box items. So you will not find these things in the textbooks and all those things. So, but these are very important things which we have to observe, and especially the accidents and mishaps during drug administration is the most important thing. In spite of our labeling and taking a lot of care, anesthetist means a very careful person. The other name for the anesthetist or a synonymous word is a careful man may be called as an anesthetist. He will not believe anything unless he himself loads the drug. So unless a trusted person with him loads the drug. So these are all the things that we have been observing since our profession started, and whatever Dr. Giri told, there are a lot of things that can happen even in the experienced hands, even the most suspicious, with the most suspicious people, things can happen. So as you practice, definitely you will see some time or other you will land in one or other mishaps. So even then, of course, there is a lot of advantage with the monitoring equipment nowadays. So now we could realize these mishaps early and revive them at an early stage. So thank you very much, Dr. Venkatagiri. You have done a wonderful job. Thank you all. Thank you. Everybody has done a wonderful job. I cannot remember the names. Thank you.
Thank you, sir. Thank you very much. Now I hand over this stage to Dr. Periya Swami, who is the secretary of the Pudukkottai ISA. Dr. Periya Swami.
Sir, Dr. Meenakshi Sundaram.
Meenakshi sir is there.
Sir, yeah.
ALM.
Meenakshi sir, please. You are in the marriage or in the car? Yes.
Sir, audible?
Yes, you
yes.
are audible.
Sir, I'm
Yes, sir.
He must be with some VIP
He's traveling in the car.
in the car.
I think it is we are not getting the line properly from Meenakshi sir.
Yeah.
He must be traveling.
Yeah. I think we can close the session with the permission of chairperson.
Yes.
Yeah.
We
Thank you.
Meenakshi sir.
Thank you, sir, Dr. Deshpande sir, for wonderfully navigating the session. You have done a very great job, sir. The topics were very useful for the postgraduates and budding anesthesiologists. Especially our past president, Dr. Venkatagiri sir, has elaborately mentioned the accidents during anesthesia. My personal thing is, as a human being, we used to commit mistakes, but you should think twice, thrice, umpty number of times what has gone wrong, and you should learn from the mistakes. I suggest to the postgraduates, follow protocols. Our senior stalwarts who have assembled here are put so many protocols for safe anesthesia practice. You should follow protocols. I now invite our treasurer, Dr. David, to deliver the vote of thanks. Over to Dr. David.
Yes, sir. Good evening to all. On behalf of ISA Pudukkottai, first I would like to thank our academic chairman, Dr. ALM sir, for successfully conducting the 46th online webinar. Thank you very much, sir. And special thanks to today's chairperson, Dr. Ashok Vasantrao Deshpande, sir, HOD, Department of Clinical Skill Lab, Bharati Medical College, Maharashtra, DC member of ISA National, for sharing his experiences. Thank you, sir. And I'd like to thank today's speakers, Dr. Venkatagiri sir, past president ISC National, and Dr. Priyadarshini, Dr. Dilip Kumar, for very useful and excellent academic session. And thanks to other faculties and postgraduate, like Kirola A1 Logic for technical support. Thank you all.
Chakra sir, thank you very much that you have joined.
Thank you all. Thank you all.
Thank you.
Wonderful lecture. Wonderful session.
Thank you, sir. Thank you.